Good evening, everybody. Welcome to our ninth session of our Saturday series. Thanks to ORDI for organizing this and to AOCN Association of Child Neurology India, which is a budding group. And it's my pleasure and privilege to introduce our eminent moderators who will do the honors of introducing the speakers. We have with us Dr. Shefali Gulati, who's the head and director, coordinator of the BM and training program in All India Institute of Medical Sciences, New Delhi. She's known to everybody, all of us here. She's also the president-elect for the Association of Child Neurology India, which is our BPNA equivalent, and has won awards and numerous publications. Then we have Dr. Gauri Pasi with us, who was trained in AIMS and is now a pediatric neurologist and the head of the Department of Pediatrics at Choithram Hospital and Research Center in Indore, and has authored multiple books, chapters in books and publications, and is on advisory boards. So welcome to both of you. Thank you so much for accepting this invitation. On to both of you.
Well, it's my great pleasure to introduce Dr. Karuna Shekhar, who's the first speaker. I was so intrigued by her topic because I'm a great fan of Agatha Christie. And she's going to speak about the imaging approach to gray matter disorders, the Hercule Poirot technique using ORDI method and little gray cells. She's a pediatric neuroradiologist in CHOP, Philadelphia. She's an assistant professor in pediatric in clinical radiology in the University of Pennsylvania. She was trained in Grant Medical College, Mumbai, and then went on to do fellowships in California and Marsden Hospital, Boston. And she has authored several chapters in many textbooks. And she's been an invited speaker and several international neuroradiology conferences. So it's my great honor and pleasure to hand over the mic to Karuna. Please start, Karuna.
Okay, I should be allowed to share my screen. Can you guys see my screen?
No, not yet.
Not yet, okay. Now?
Yes, now we can.
Is it on full screen mode? Or?
No, not yet. Yes.
Now?
Yes.
Yeah, and can you all hear me well?
Very well. Loud and clear.
Okay. All right. Thank you, Dr. Gauri, for that introduction. And I would like to thank the organizers of ORDI. It's an honor to be invited to talk. I think this is such a wonderful series that has been conducted, and it takes a lot of effort to put together such a thing, and that too in such trying times as present. Thank you for inviting me. And I've tried to log on to a few of these sessions, and I have really learned a lot from these sessions. And I hope to listen to the video recordings later on, the ones which I have missed. Before I start, I just want to say a special big hello to all the neurologists and all the physicians that I have worked with in Bangalore and Mumbai. I have always learned from my neurology colleagues and continue to learn from them. And it is a great pleasure to actually see some of the names and look at the faces, who I have worked with before in Bangalore. So today I'm going to be talking to you on imaging approach to gray matter disorders. It's a really large topic and quite challenging to give the gist of it in just about 25 minutes. But this is what I'm going to do. This is going to be my talk outline. I'll be just talking briefly about the anatomy. We'll talk a little bit about the technical considerations in imaging. We'll talk why I chose this title for as the Hercule Poirot technique. And then we'll look at some common imaging patterns, and the approach that I've taken today is going to be based on the etiology or the cause, and we will look at several case-based approach to these. And my focus will be mainly on basal ganglia and on neurometabolic disorders. We'll show a few pertinent cases regarding toxic conditions, some inflammations, particularly acute necrotizing encephalitis of childhood and COVID infection. And so let's begin that. So right from the beginning, I want to tell you that, it is in this part of the world, gray is spelled with an A, that is the American way. And what I learned as in school, and for half my life, it was gray because that is the way it is spelled in UK and the Commonwealth countries. And since half my life I spelled it with an E, you will see that, I may have used gray with an A and E, mixed in my talk, I think that is because you spend half your life in the UK way or the Commonwealth way, and then you come the American way. So, so why is it gray matter? Is it really gray? Is the color really gray? Actually, it's a little bit of a pinkish gray. If you have looked at dissections or cut specimens, we have this very interesting brain cutting sessions we go to and we learn from. And I always think it doesn't look gray. It looks more of pink or pinkish gray. Anyway, so the gray matter, is composed of, it stays in the cortex in a group of nuclei in the basal ganglia, the thalamus, and also packed as nuclei within the infratentorial, the cerebellum, the brainstem, and also within the spinal cord. The major parts of the basal ganglia, these are nuclei which consist of the caudate paired nuclei which stay along the ventricles, the putamen, which is of the lateral portion here, the globus pallidus, which is the small medial portion here, and the thalamus is what flanks on either side of the third ventricle. The lentiform nucleus is the combination of globus pallidus and the putamen. And the corpus striatum is the caudate nucleus and the putamen, and it is divided in between by the internal capsule fibers between. And because they are called like strips of gray matter on either side of the internal capsule, that is why the name striatum or corpus striatum is given to it. And so the best way to evaluate gray matter disorders is by utilizing MRI technique. Because of its high resolution and sensitivity, it can really make out the differences and the details of the basal ganglia, which is not possible with, say, the computed tomography or CT scan. So to assess these disorders, we do the basic T1, T2 flare sequences. We also utilize what is called as a gradient echo or the susceptibility weighted imaging. This is specially to look at mineralization and blood products, which is very important, particularly in the NBIA, the iron deposition disorders. And we also use diffusion weighted imaging for some specific acute presentations of some disorders. For most of the conditions, we may not need contrast. It's only for some infections, inflammation, and neoplastic conditions that we need to give gadolinium injection for evaluation. CT scan still continues to be done. We do it without contrast for some cases where it can be very beautifully assessed. It's very easy to assess calcifications. And earlier on, for some acute crisis of these neurometabolic disorders, CT used to be the imaging of choice. But at our institute, a lot of the CT is being replaced by fast MRI because it's a shorter study and also gives more information than what CT can offer. And in certain cases, we make use of MR spectroscopy so that we can assess the levels of metabolites. And in some cases, it can be really specific to diagnosis, whereas in some cases, it can just sort of kind of aid us in what is the pathology. And since we are dealing with the pediatric population, we have to remind ourselves that we are committed to imaging gently. We are mindful that we use techniques which have radiation, and not just that, even the use of gadolinium injection, because we can have issues with gadolinium deposition if these kids get multiple scans. Plus, in the pediatric age group, you have the challenges, particularly in the neonates, infants, and young children may need sedation, and in some cases need anesthesia. And the entire push of the entire community, the pediatric community, is to minimize sedation and anesthesia. And we use a lot of immobilizer and feed and swaddle techniques to get the imaging done. So why Hercule Poirot? Actually, when I was talking about this to some of my trainees, I was surprised that this generation of trainees, they don't read much of Agatha Christie. They read a lot of other Marvel comics and some other series. But so I had to tell them that Hercule Poirot is a fictional character. He's a detective from Belgium, created by the author Agatha Christie. And one of the favorite things that Poirot likes to say is the use of little gray cells. And I said that I have to make this association. We have a lot of things to remember in medicine, and I think the best way to remember them is by associating them with some things that you can never forget. And one of the things Poirot always believed, that the best tool to solve all his mysteries and criminal cases were by using the gray cells of the brain. And the way he approached to solve a case is pretty much like putting pieces of a puzzle, and that is really what we do in our when we are dealing with evaluation of gray matter disorders, and to arrive at some difficult diagnosis, which are pretty challenging unless you put these pieces of the puzzle together. Poirot technique mentions order, method, and the little gray cells. And in medicine, we pretty much follow the same thing. It's observation, reasoning, and knowledge. And I think this is what we are going to apply to kind of help us arrive at some of these challenging diagnoses. So moving on, so I'm going to be taking this approach to discuss several conditions based on the etiology. And I like to keep things very simple. So I like to put them in like very big buckets. So any case that you're looking at, you need to know the clinical presentation, the evaluation, the physical examination, and lab evaluations if you have. Many times when the patients come for imaging, we may not have all the results of the labs and all that. They may have just drawn samples and they must be still under evaluation. So the MR is often the first clue to the diagnosis, or the first part of the puzzle that comes. And then later on, you have to correlate with the tests, the results from the lab investigations, as well as genetic testing, which is a very important part of a diagnosis of the neurometabolic conditions. So if you have to look at all the causes which affect the basal ganglia or the gray matter in the brain, so this is basically the big list of conditions, and they are roughly in the order of their incidence. So you are going to be seeing a lot of cases which will be caused by hypoxic ischemic injury from various reasons, vascular abnormalities, and then all the others listed. But today we won't have time to discuss all of them, and only the ones highlighted in green are what I'm going to be talking today. In general, the metabolic conditions are typically produce symmetric findings on MRI, whereas vascular etiologies usually will not be that symmetric. Even the infectious conditions may not be completely symmetric, but they're nearly symmetric, like in many times. And neoplasms, of course, are not going to be symmetric. And some of the common ones are the glial tumors and some of the spongiform changes that you may get with neurofibromatosis 1. So let's start looking at cases. So I'm starting with this first case. This was a 7-month-old with status epilepticus following a brief respiratory illness. And clinically, the concern was for ANEC, or acute necrotizing encephalopathy of childhood, quite rightly so. That is what was shown on the imaging. And I have images here from T2 weighted scans. And we say it is T2 weighted because you have bright CSF. And here we have the susceptibility weighted imaging, which is good for evaluation of blood and calcium. So on the T2 weighted images, the most striking finding is this diffuse swelling of the thalamus with hyperintense signal. And this also showed restricted diffusion. And on the susceptibility weighted imaging, you can see that there is increased susceptibility, the dark signal that is there, saying that it is hemorrhagic. And we have some techniques on our SWI that we can differentiate blood from mineralization in most of the cases. So utilizing that, this was acute presentation, this is hemorrhagic, and this is consistent with the typical picture of acute necrotizing encephalopathy of childhood. And a important thing that we need to know that this can be caused, it can be familial. The susceptibility to getting ANEC is because of a mutation in the RANBP2 gene. And we actually had very recently, we had a case of two of twins who both got ANEC within a matter of few months from each other, just proving the point that, you know, they both had this mutation of the RANBP2 gene. So moving on, the next one, since it's so current and topical, we need to know this is something which was actually one of the first cases which was reported. This was in an adult patient, but similar to what it can do in children, you know, and any viral illness, this produced acute necrotizing encephalopathy. This is a CT scan showing hypodensity within the thalami and edema, and the MRI scan again showing this diffuse edema as well as bright signal on both the T2 as well as the flare images here. Recently there was this very nice work which was put in by the collaboration of several pediatric radiologists, neurologists, and infectious diseases people all over the globe, in fact. And this is like the biggest collection of children with COVID and the neurological manifestations which were have been studied. And they did see that this pattern was seen with COVID, although was not one of the more common patterns. The other patterns were more common with COVID infection in children. Now moving on to the next group, this is with caused with toxicity. So here, this was a 1-year-old girl. This patient had tuberous sclerosis, but she also had spasms, and that's why she was put on vigabatrin. This is a case, I think, nearly about 10 years old now. I think when I was a trainee CHOP. So this one we didn't know at that time, and we were wondering what is the reason for this bilateral hyperintensity in the globus pallidus, in the thalami, and this patient also had further signal abnormality and restricted diffusion, even in the tegmental tracts as well as the dentate nuclei, and there was definitely no history for any hypoxic injury. And so we were puzzled at that time. We were not aware of this condition, but then it became pretty clear that this was a pattern we were seeing, particularly when these patients were on vigabatrin. So this was a transient demyelination, right? It was a toxicity, which was due to vigabatrin therapy, which was reversible in most cases after the treatment was stopped. So you should remember this pattern, particularly if there is a patient who is receiving vigabatrin, typically for infantile spasms, and this pattern can occur, and you should be familiar with this. Another condition in the toxic etiology group is something which we would see more in the adult population, but can also happen with older children and adolescents, is due to carbon monoxide poisoning, which could be either accidental or sometimes we had a case that was actually more like a suicidal suffocation, being locking oneself in a room with, with things burning. So you should be familiar with this. The hallmark of this is the pallidal necrosis, the bilateral foci hyperintense, T2 hyperintense foci in the globus pallidus. This is a classic finding that you see in carbon monoxide poisoning. So now we move on basically to the next group. And when we are evaluating gray matter disorders, what are the conditions that would primarily affect the cortex? So this is the list of conditions, but I think I'm going to talk only about the first one, NCL, neuronal ceroid lipofuscinosis, because this is a condition that produces dramatic atrophy. And you can see this is an old case. This is from 2007. This was at that time we were not doing genetic mapping, and this was labeled as the late infantile group. I don't know, it was presumed to be type 2. And you can see that this is how it was in 2007. Maybe there was some early onset of cerebellar sulci being seen and some maybe early cerebellar atrophy. But look at that, in 3 years, you can see there is massive progress of the atrophy, and in fact the cortex, they're almost as thin as blades, so there is severe atrophy predominantly of the cortex, both supratentorially as well as in the intratentorial brain. In this case, I would say that both the supratentorial and cerebellar atrophy was nearly equal, but in the earlier stages it's usually the cerebellar atrophy which precedes and is more prominent in the NCL type, particularly the type 2s, and in several of the NCL types. So what are the salient features of NCL that we may see on imaging? So the first important finding is volume loss, which can be diffuse. And in many cases, as I said, the cerebellar atrophy is out of proportion, is more than the cerebral atrophy. And white matter hyperintensities is another hallmark. They could be just bands of hyperintense signal on T2 in the periventricular location, but can quickly increase to involve almost the entire white matter. And some of the zones like the insular and subinsular cortex and posterior limb of internal capsule are some of the areas where you may see these bands of hyperintensity. And in the late stage, it's almost always diffuse. And the other characteristic feature on imaging for NCL is the T2 hypointensity in the thalami and sometimes even in the basal ganglia. So I have here, so since that time, I think we have now identified nearly 14 types of genes, and not all, we are still learning a lot more about the neuroimaging phenotype of these conditions, and some of these occur more commonly, but we see a varying combination of these above mentioned findings in this group of disorders. And I have here one case. This had a gene identified. This was the type 2 CLN type 2 gene in this case. And you can see the manifestations of diffuse volume loss, the atrophy. There is diffuse white matter hyperintensity on these FLAIR images. FLAIR images, think of it as the brain, which looks like T2, the brain parenchyma, but the CSF is suppressed and is going to be dark. That's why you can look at the bright signal adjacent to the ventricles, which may sometimes be difficult on the T2-weighted sequences. So the FLAIR sequences beautifully show the white matter signal abnormalities, as you're seeing here in the posterior limb of internal capsule, in the subinsular white matter, and also in the periventricular white matter. And also the other finding that you can see, I hope you can appreciate, this is the hypointensity, which is seen in the thalami, which is a characteristic feature of NCL. And another important thing that we need to know is that there is now treatment which is available for the CLN2 disease. And I think Dr. Williams will be talking about it, and I'm eager to listen to what she has to say. So that is a really good thing to know about the treatment options for NCL. So now we move to another category of conditions. And now this case is of a 2-month-old of Pakistani ethnicity, and this family, there was the findings of microcephaly, extreme irritability, dystonia, gross motor delay, bradykinesia, and seizures. And this was the MRI study done at that time. So these two are diffusion weighted images, and these are the T2 weighted images. So the striking finding here is the swelling and bright signal and restricted diffusion in the putamen. You can see that it's pretty characteristic, almost the entire putamen is involved. In this case, we are also seeing involvement here in the thalamus in this section here. And also The other thing here is the involvement of the perirolandic white matter. This is the ADC map, that's why it's dark here. And you can see those areas also show hyperintensity on the T2 weighted images. And when you see this extent of symmetric swelling of the putamen, and you have this genetic testing and the result shows an SLC19A3 gene mutation, you have the answer, you have the diagnosis. This is biotin thymine responsive basal ganglia disease. This is a condition, it is an autosomal recessive condition which causes subacute encephalopathy, confusion, seizures, ataxia, dystonia. And the thing is that if it is left untreated, it can lead to coma and even death. And the early treatment is possible with a combination of biotin and thymine and is actually life-saving. So this is a pretty, has a very nice radiological signature, and we know the gene for this, and so, and also a treatable one. So we should be able to identify this condition. Something in the toxic group, which is again seen in older kids and maybe in adults, is Wernicke's encephalopathy, which shows similar kind of involvement of mainly the areas of the thalamus adjacent to the third ventricle and the periaqueductal region, T2 hyperintensities. And this can happen either with toxicity with methanol or underlying liver conditions can result in Wernicke's encephalopathy. So now we move to one of the biggest disorders of the gray matters condition. This is Lee's disease. Now this is a disease which is kind of, has a classic involvement, not just of the basal ganglia, but it typically involves all the gray matter of the brain and can also involve that of the spinal cord. So here we are seeing a bright signal in the putamina mainly. And if you see the diffusion weighted images, the anterior putamen is more involved. That is showing the restricted diffusion, whereas the rest is actually showing facilitated diffusion or just edema. And this has been described as the target sign on diffusion weighted imaging. And then this one has a mutation in the MT&D6 gene. There are multiple genes which have been identified in Lee's disease. And Lee's syndrome, as it is the better way to call it. This is a subacute necrotizing encephalomyelopathy. And it's a heterogeneous mitochondrial disorder with a bunch of genes which have been identified, results in progressive neurodegeneration. And these are the symptoms that it may be presenting with, majority of them present under the age of 2 years. And when I used to learn this, mainly affecting just the putaminal regions. That was what we used to learn. But there is also, you can make use of MR spectroscopy, which shows the presence of lactate in these lesions. So what I wanted to tell is that when I was learning this, we used to think only certain regions are involved. But in the last year, there was this excellent work done by my colleagues, clinical and research colleagues at CHOP, who extensively reviewed about 200 cases of Lee's syndrome. And they put forth, the several neuroimaging findings. So it is not just the putamen, but entire, all portions, not just the striatum, but full portions of the basal ganglia, the thalamus, regions of the cortex, brainstem, as well as the spinal cord, which can get affected. So it's a vast number of imaging phenotypes can be identified in Lee's syndrome. And this is the entire list, and they in fact even made out a map which shows us the distribution of various findings corresponding to the different gene mutations in Lee's syndrome. So now we thought that we learned everything about Lee's syndrome, and then recently we had this case in an 18-month-old with regression and weakness of thalmoplegia, and they were the clinical symptoms were highly suspicious for a mitochondrial metabolic disorder. And there was signal abnormality, but it was just in the anterior putamen. And the clinical features were Lee-like, but there is no genetic confirmation yet on this condition. And we thought that we knew everything about Lee's, and then suddenly there is this other condition that we come to know about. And this is something which has Lee-like lesions, but this is condition called as MEGDL, which is the 3-methylglutaconic aciduria. Psychomotor delay, hypotonia, can get sensorineural hearing loss, and clinically and imaging Lee-like lesions. But the characteristic feature here is that only the ventral putamen is predominantly involved, and you can actually get some like a target or a central area of necrosis in the anterior putamen, and this has been described as the putamenal eye, and there is a specific gene mutation, this SERAC1 gene, which has been identified in cases of MEGDL, and the pattern classically is this ventral putamen, or called what is called as the putamenal eye. So we have to wait and see if we get genetic confirmation on the earlier case that I showed you. And this is a paper from some colleagues in India who have showed these cases of MEGDL with the typical anterior putamenal involvement in the early stage with restricted diffusion, and later on with volume loss and Malasic changes. So remember this condition of MEGDL with the involvement of the ventral putamen. Now, this is something which is typically known to most of this condition when it is a case of jaundice, unconjugated bilirubinemia, hyperbilirubinemia, and the conditions, these symptoms may present with somnolence, hypotonia, opisthotonus, and a very characteristic high-pitched cry. And here, I have been showing you T2 weighted images so far, but for this case, I'll show you T1 weighted images, which show the classic hyperintensity in the globus pallidus and substantia nigra. And this is bilirubin encephalopathy, connectorous, and it can be seen in patients with primary liver disease. And you get increased signal in the globus pallidus, hippocampi, substantia nigra, and even the dentate nuclei, and in the chronic stages, it leads to volume loss. Now, this next condition that I'm going to show you is a very interesting case. We are still dealing with the metabolic disorders. This was a 13-year-old girl of Korean ethnicity. She presented with several months of difficulty with tongue movements, tremor, and which was affecting her writing. She was a good student, but she had been, failing her exams, and grades were falling. And she had visited 6 months ago to South Korea, and the parents actually were worried about substance abuse. But when we did the MRI, and you can see that there are bright areas in the putamen, and you can see the next step that was done was, to look at her eyes, and there was this characteristic KF ring, the Kaiser-Fleischer ring in the cornea. And this gives you a clue that this is a condition that we are dealing with inherited copper metabolism disorder and accumulation of copper in various tissues, especially the basal ganglia, and the second organ to be affected being the liver. We are dealing with Wilson's disease here. The findings, it can affect not just the putamen and the regions of the caudate and thalami. It can also involve the substantia nigra, and that is producing the typical, what has been described as the face of the giant panda at the level of the midbrain. This is a characteristic feature for Wilson's disease. Krabbe's disease is another disease. Now here it also has a gene identified, and in this condition you get hyperintensity in the thalami and basal ganglia, and the findings are of enlarged optic nerves and also other cranial nerves, which can also enhance. So this condition is also called as globoid cell leukodystrophy, and it can have different forms, mostly presenting in the infantile with age, with irritability, seizures, and progressive psychomotor retardation and vision symptoms. So the characteristic features here, along with the signal abnormalities in the basal ganglia, as well as the white matter, thalamus, even in the cerebellum and dentate nuclei, is the enlargement of optic nerves and other cranial nerves. I will quickly run through some more since I think I'm going a little over time, but I do want to talk about the NBIA briefly. So this is glutaric aciduria. This is a condition which is characterized by enlarged, widened sylvian fissures, you can see, which has been described as the bat wing appearance. In this condition, you can get hyperintensity and restricted diffusion in the acute phases. in the basal ganglia, striatum, as well as the thalamus. This condition, because of the widened spaces, they can get subdural hemorrhages with very trivial trauma. And this can be a mimic of abusive or accidental, non-accidental trauma, is something which we should remember. Now I can move on to the NBIA group, which I want to touch briefly on. So this is a young patient, 10-year-old, who presented with psychotic features, extrapyramidal symptoms, and visual and auditory hallucinations. And you can see on this MR that there are these focal T2 hyperintensities in the globus pallidus, and you can see on the SWI, or the susceptibility weighted images, you have these foci of susceptibility, and that with a central halo, which is not so well seen in this case, but that has been likened to the eye of the tiger sign. And we are now talking about the pantothenate kinase deficiency, or the haloverdin spats, also what was known as previously. So pantothenate kinase associated neurodegeneration belongs to the brain ion accumulation and BIA disorders, and can present with dystonia, dysarthria, and chorioacidosis. The classic finding is the pallidal T2 hypointensity, and surrounded by in the medial globus pallidus with surrounding bright signal and a central hypointensity, which has been described as the eye of the tiger. A little trivia about this is that when Haloverine and Spatz initially described the findings, these were studied from brains of institutionalized and disabled children and adults who were actually murdered in the Third Reich by the Nazis. So that's why this name has been discontinued, and we use the term by the gene that is identified. And since then, in NBIA, several genes have been identified, and these are the various conditions that have been, belong to the family of brain ion accumulation. And I have just a couple more cases of this to show. This was a case that came to us. She's a 9-year-old girl, and she had cramping and progressing to dystonia and torticollis. Some other important clues in her case were alopecia and hypogonadism. So she has the hypointensity of the T2, which is also showing increased susceptibility, both in the globus pallidus as well as in the substantia nigra. And we thought, okay, we know that we are dealing with the NBIA group of disorders, but this didn't have the eye of the tiger, but it had some other things in addition to this. The findings of alopecia and hypogonadism, and the gene identified was DCAF17, and that was the clue to tell that this is the NBIA group, but this is the Woodhouse-Sakati syndrome. And the clues here are the alopecia and hypogonadism. Imaging-wise, she's still prepubertal, but post-pubertal, these patients actually have hypogonadism, so they may have very small pituitary glands seen on imaging. And this is actually her clinical picture that shows the patchy alopecia that she has because of her hypogonadism. Some other conditions in this group are the BPAN, which is the beta propeller protein-associated neurodegeneration, and the imaging correlate to this is that there is actually a bright halo in the substantia nigra, which is affected more than the globus pallidus in this condition. And this, of course, it depends on the identification of the gene mutation. Another one in this group is the PLAN. And in here, the imaging correlate is that both the globus pallidus and substantia nigra are affected. They show susceptibility. In addition, there is cerebellar atrophy in this group of conditions. But many times it's difficult just by imaging, and you need to go back and look at and see what was the gene identified to be able to make the diagnosis in this case. So just to finish off, so here are all these actors who actually played the role of Hercule Poirot, either in movies or on television series. And you can see that each one has a distinct look. They are all individuals which are distinct, but there is a common pattern or some few traits which run common through all of them, which are kind of like the hallmark of what was Hercule Poirot's as a character description, which includes his typical mustache, his bald head, his impeccable dressing sense, and his the accent with which he speaks. So we can, this is the same thing that we have to identify or use as a pattern, that each case is different, but there may be some traits or some common imaging phenotype that we can identify when we study few conditions and then come to a diagnosis. Have used these references. These are excellent articles in recent times, which have described in detail and given long lists of several conditions. I have shown only about 1/10 of the conditions which may be discussed in these papers, particularly this group this is a work of collaboration over several departments, I think all over the globe, and they actually compartmentalize them into 4 basic types of patterns. I think I would encourage everybody to go and take a look at this paper. And also they have come up with some kind of an algorithm, which is pretty intensive, but it is very helpful. I think in day-to-day practice, sometimes it might be difficult to go through all the limbs of that. But I think if you at least even try to put them into the big categories, it's a big help, and then take use of the genetic testing and the other lab investigations to come to the diagnosis. So some other approaches can be based on the anatomy and conditions affecting each region, or you can look into details of the dominant patterns and of the signal and the changes seen on MRI. What I showed you was just based on etiology, but you can combine all these approaches and come to a more diagnosis. But you have to remember, it is very challenging to diagnose gray matter disorders because there is a significant overlap both in the clinical and imaging findings, and it also, the findings depend on the stage of the disease. And in many conditions, you need to do serial MRI. Genetic testing is an important part of tool that we need for this diagnosis. It requires a lot of money and time to come to a definitive diagnosis, and of course, it is a multidisciplinary approach to arrive at the diagnosis. So to summarize, we looked at different gray matter disorders by their etiology and looked at some characteristic imaging patterns. The imaging phenotype, as you can see, is just expanding. Even by the time I finish this talk, also there may be some new conditions which may be described. Genetic mapping is very important. And we looked at some of the challenges in the diagnosis. And you have to remember, it's all teamwork and collaboration. And the future, I think we are going to be using a lot of artificial intelligence. I think the group from Sydney has already kind of put forth some kind of this thing where you can feed a lot of data and feed your findings and genes and the lab findings, and you may be able to arrive at a diagnosis. But in the bottom of all this, you still have to use your gray cells. You cannot rely completely on artificial intelligence. And I would like to acknowledge all the patients and families for the use of their images, and the various departments at CHOP because of their work, which I could show you all these cases. And with that, I thank you very much for your attention and look forward to hearing the other 2 lectures. I'm sorry I went a little over, but I apologize for that. But thank you for the opportunity, and we'll be happy to take questions at the end.
Thank you, Dr. Karuna, for an excellent talk. We'll have the Q&A in the end, if it's okay with you. So that's how the format is, so that we have all the talks. And now I will call upon Dr. Ruth Williams, who has been trained from Nottingham, and has a research interest in Batten disease and epilepsy and ketogenic diet, and currently a principal investigator of a clinical trial in UK on BMN 190 in NCL2. And she has received multiple awards, including Well Child 2012 award, and she has many credits to her resume. I would now, without wasting time, request Dr. Ruth Williams to kindly take over and talk what is new in NCL. Thank you.
Thank you. So I am trying to share my screen. So if you could let me know when it appears.
It's there. It's on. It's on full screen. Perfect.
It's there.
Yes, perfect.
Perfect. Okay. So thank you so much for inviting me. It's a great pleasure to be with you all this evening. It's the afternoon in the UK. My name is Ruth Williams. I'm a paediatric neurologist at Evelyn Children's Hospital, which is close to the River Thames, opposite the Houses of Parliament. Sorry, let me move on my screen. Just bear with me a moment. Sorry. So I'm going to be talking about this group of disorders, and all of the children in these photographs have one or other type of Batten disease or the NCLs. So they are a heterogeneous bunch of conditions. So I'm just going to remind you a little bit about these disorders. We're going to think about the unmet need for new therapies. I'm going to kind of set the scene for where we got to about 10 years ago. I'm going to use the example of CLN2 disease, and you've already heard from the previous speaker a little bit about this condition and the neuroimaging findings, which was really important, and the introduction of cerulipinase alpha, which is also known as Brineura. Now, just a small correction for the credits and the nice introduction. I was PI for this study in the UK for a very short time, and then the study transferred to Great Ormond Street, so I was no longer part of that study, but I'm going to share with you some of the results and some of my thoughts about that. So the goals, my goals for you really are just a little reminder about these disorders, thinking particularly about the need for early diagnosis, because in some of them we now have treatments available. Disease-modifying treatments are on the horizon. And we're going to think a little bit about new therapies for rare neurological diseases and what the requirements are. So I call these disorders Batten disease because that's what the families in the UK call them. It's easier than the neuronal ceroid lipofuscinosis, which, to be fair, is a bit of a mouthful. It's a family of diseases. Usually onset is within childhood. Most of the genetic types follow an autosomal recessive inheritance pattern. They are all neurodegenerative. They're characterized by an abnormal storage material in neurons and other cells, which autofluoresces under the light microscope and can be seen in a characteristic pattern when you examine cells at the electron microscope level. Most of these disorders have the clinical features involving seizures, blindness, and a progressive, relentlessly progressive cognitive and motor and a behavioural symptomatology. And death occurs in untreated children in childhood and early adulthood. So as you've heard already, in the good old days when genetics was simple, we thought there would be one gene and different mutations would lead us to the different clinical phenotypes. But that's not the case. We now have at least 13 different genes responsible for this group of disorders. We know that mutations in several different genes give rise to a kind of a late infantile onset phenotype. We know that for some genes, for example, CLN1 mutations might give rise, depending on the mutation, to an infantile onset phenotype or to a juvenile onset phenotype. So the genetics is valuable, but not straightforward, and it's a little confusing. Importantly, they seem to fall into two groups. There's the lysosomal enzyme deficiencies, so mutations in a gene called CLN1, which usually gives rise to an infantile onset disease, previously called infantile NCL. We now know that's due to an enzyme deficiency, the enzyme PPT1, palmitoyl, I always get this wrong, palmitoyl protein, no, I've got it wrong. I'm not going to try, PPT1. We know that mutations in CLN2 cause another lysosomal deficiency, the enzyme TPP1, and in the very rare congenital onset disease caused by mutations in the gene CLN10, this is also a lysosomal enzyme deficiency, cathepsin D. So some of these NCLs, Batten diseases, are caused by lysosomal enzyme deficiencies. And of course, that has implications for the sorts of treatment that might be helpful. But the others are likely to be membrane proteins. And for many, we still don't know the function of the protein, and we don't really fully understand the biochemical pathway. So that poses problems when you're thinking about new therapies and delivery of therapies. I just want to mention neurodegeneration, and you've seen some beautiful scans already, so I'm not going to talk about the scans. But neurodegeneration, the children in the NCLs and other neurodegenerative conditions, the initial stages, the child is healthy, achieves normal developmental milestones, and then development plateaus in these grey matter disorders. The progress slows down and then it plateaus, and then you see regression, loss of skills. And of course, that's what we as doctors, that's when the children come to us. But very often, the parents have been worried for some time. The children are just not right. They're not making the progress at the rate that their parents expect. But of course, they're still within the normal range, and their parents are often reassured by healthcare professionals. So by the time we make the diagnosis, they're losing skills very often. And effectively, the diagnosis is late. It's well into the pathological process, which by that point is irreversible. And that has implications for treatment, disease-modifying treatment, when you're trying to find ways to stop that relentless progression. So how do we diagnose? Well, in the good old days, when we just had microscopes, I said that these conditions were characterized by this autofluorescent abnormal storage material. That was the way we diagnosed them, on the basis of a tissue sample, appendix, rectum, conjunctiva, muscle biopsies, and we were able to give a diagnosis of one of the NCLs. As time went on in the 70s, we had more, we had electron microscopy, and we were able to differentiate on the basis of the appearance of the storage material. So in CLN1 causing infantile Batten disease, for example, we would see these granular osmiophilic deposits. Late infantile Batten disease caused by CLN2, we see these kind of curvilinear profiles. And in juvenile onset Batten disease caused by CLN3, we see fingerprint profiles. And in some of the other variants, we see a mixture of these things. But we were then able to make the diagnosis of a particular subtype. But it really wasn't until enzymatic testing, until genetic testing became available to us, that we can make a truly NCL type specific diagnosis. And I would say now that the gold standard for these kind of rare metabolic diseases is a genetic test where you are able to identify two pathogenic disease alleles. So that's the background. Let's think a little bit about new therapies. Towards the genes were beginning to be identified 1996 and onwards. So then we had access to, so we had a gene, for example, for CLN2. We knew that it was an enzyme deficiency. So, where does that follow? Enzyme replacement therapy, well, we're not there yet, but maybe bone marrow transplant, for example, would be a way of delivering the enzyme to the brain. Bone marrow transplant was tried in a small number of patients in Finland and the UK, and it was clear within a small number of years that it really wasn't effective. It didn't alter the disease course. Families were very keen to travel to the ends of the earth for treatment, and so a number of families travelled to China for stem cells, which were given either intravenously, intrathecally, or intracranially. Some formal clinical trials got started in the US for stem cell therapy, and the results were a long time coming. And I think, overall, it wasn't really, it didn't really make a difference. Early in 2004, 2006-ish, the group at Cornell in New York began a phase 1 trial to determine safety and efficacy for a gene product for the CLN2 disease children. And they really thought through the ethics. And I think this is why this study was really important. Overall, it wasn't successful, but they kind of went through the proof of concept. So they started off by recruiting just 3 children who were very severely affected at an advanced stage of the disease, because this is the first time anything like this had been done. They use a adenoviral vector and the delivered gene therapy product via 6 intracranial injections. And these two are my patients, and this photograph, you'll see it again, but I think it just illustrates these both children are affected by this disease, and they travelled both to China and to the US for experimental treatment. The group at Cornell published their methodology, and they published their thoughts about how to recruit patients for this kind of study, thinking about control groups, which isn't really an option in a rare disease, thinking about proof of concept in the most severely affected children, and then recruiting subsequently less severely affected children, and thinking about outcome measures. So come 2010, we have a situation where there's some early trials in progress or with early results. We know that families are prepared to travel. We have a variety of animal models, naturally occurring and genetically engineered mice. We have imaging studies which could be quantified to show the rate of progression of disease. So we have a kind of a biomarker, that's a radiological marker that might be used to monitor disease progression. And we have a number of family support groups around the world, and I'll come back to them later. We also have an established international registry, which has been set up by my colleagues in Hamburg, where they're collecting clinical data and uploading it into an international database. And around 2010, 2011, there was a European grant, and a number of other countries were then became involved. And so this is an international collection of clinical and diagnostic data for children and young people affected by all types of Batten's disease. And so this was really important in providing a cohort of historical controls. You've met these two children before, so I'm going to now talk a little bit more about CLN2 disease. For me, this picture kind of illustrates the disease. So the young lady was developmentally normal until she was about 2. She was a really chatty, strong personality 2-year-old. And she was diagnosed after her brother. Obviously, she's much younger. Her brother, the diagnosis was made as that the Cornell study was taking off. So he went for treatment, and I think he was in the more advanced group. And then his sister was diagnosed pre-symptomatically in the hope that she would be able to access early treatment. And her diagnosis was a shock to all of us because she was developing normally and was very chatty. But this tells the story of neuroregression, how tragic this illness is, the burden of illness, burden of symptoms, and the desperate need of families to travel the world to get treatment. So CLN2, I've mentioned already, it's the disease is named after the gene. A huge variety of mutations have been described in this gene, and there are common mutations certainly in the Northern European population. The early features, the first feature very often in probably 80% of the children is that language development in the second year of life slows down, and some of these children are referred early for speech and language therapy. But really they don't come to the attention of a paediatrician or a paediatric neurologist until the onset of epilepsy, somewhere between 2 and 4 years of age. The seizures are often multiple seizure types, and quickly it's recognised that they are drug resistant. Following the onset of seizures, the children lose mobility, they become more unsteady, they develop myoclonus late, but perhaps they have a subtle myoclonic ataxia earlier, and often that is put down to the frequency of the seizures or the medication that's used to treat seizures. Some of the children end up being in hospital for quite some time because the seizures are so difficult to control, and then it becomes apparent that maybe it's the underlying disease process that is causing loss of skills rather than the epilepsy per se or the treatment, and they get referred for diagnostic investigations. Now, I want to point out here that the EEG can be useful as an early kind of indicator, a red flag. So in this particular disease, CLN2 disease, slow photic stimulation often elicits a photoparoxysmal response in the occipital leads early in the course of the disease. It's not always maintained later into the course of the disease. So it's an early finding, and otherwise the EEG is fairly non-specific. But this is perhaps the most important reason for doing slow photic stimulation in a young child presenting with seizures before the onset of mobility or visual symptoms, because this would alert you to the diagnosis and prompt those diagnostic investigations. Seizures become more troublesome, mobility becomes worse, and by 5 or 6 years of age, these children have lost all independent mobility. They are increasingly dependent on adults for all activities of daily living, and they're often very irritable at times. There is a very simple motor score which was developed by the Hamburg team, split into 4 different domains. The most important are the motor function and the language domain, and I've just illustrated there the motor function domain. So essentially you score 3 for normal function or your best ever function, and you score 0 when all skills are lost. And using the historical cohorts from that DEM child study that I spoke about earlier, the team in Hamburg were able to show that there is this unbelievably rapid disease progression, loss of skills between the ages of 4 and 6. And essentially you can quantify that using the simple motor scoring system, so that you get an approximate rate of decline of 2 units on the Hamburg scoring system per year. As the disease progresses, the children become gastrostomy dependent, they lose all voluntary movement, they lose head control, they develop blindness, but it's very difficult to measure visual acuity in a child who can't move and who has lost communication skills as well. So it's very difficult to know exactly how the vision deteriorates and when exactly in untreated natural history children. The study of cerulipinase alpha began in 2012, and the results were published in 2018. Cerulipinase alpha is a recombinant enzyme replacement. It is given in the form of an infusion through an intraventricular port over about 4 hours. And because it's enzyme replacement, it needs to be repeated. So the children on the trial and children who are ongoing having treatment are treated in a tertiary referral centre every 2 weeks with this infusion. There were 24 children enrolled into the trial, and the results, as I suggested before, for those 24 children were compared with the historical controls, and the main outcome measure was that clinical scoring system that I showed you. So the top graph here shows the combined motor and language domains, and the middle graph is the motor score, and the bottom graph is the language score. The historical controls are the red lines, and that's kind of reflecting that steep decline. Children were only recruited if they had some retained motor and language skills, so that it was possible then to measure any decline. So they compared the study children with historical controls, and you can see that the children who were in receipt of the cerulipinase alpha skills were maintained in comparison with historical controls over the length of the trial, which was 2 years. So this is the first time, I think, that enzyme replacement therapy for a progressive neurological disorder was delivered via the brain, and very exciting. At the same time as that study was going on, BioMarin, who were sponsors of the study, gathered together experts. They were aware that a therapeutic trial and taking a drug from the laboratory to market was going to involve a lot of other things. So they spent a lot of time working with experts internationally on diagnostic pathways and also on holistic care and kind of standards of care. And so they were able to bring us, a number of experts, together for a series of meetings. And although we all work in different centres, different countries, I was always really, I mean, it's lovely to work with paediatric neurologists throughout the world anyway, but you know, I think again and again how lovely it is that we are all on the same page, we all work with the same goals, and we are all absolutely convinced that multidisciplinary working is the best for everybody. So what's happened to the children in the trial? All of the children in the trial have survived so far. They are continuing to receive Brineura every 2 weeks. Increasing numbers of children in increasing countries are now on treatment. There is no doubt that life expectancy is increased. There is no doubt that there is a difference between children who are treated late in the disease compared with children who are treated pre-symptomatically, perhaps because an older sibling has the disease and a child was diagnosed pre-symptomatically. So there's definite indicators that early diagnosis, pre-symptomatic treatment is of value, and those children have done much better than other children. There are a number of children in the UK who had treatment before they developed symptoms, and at the age of 6 and 7 are still in mainstream school. And compared with our historical controls, at the age of 6 and 7, I would usually expect these children to be wheelchair bound with no voluntary movement, gastrostomy fed, frequent seizures. However, there are questions. The children on treatment, by and large, the epilepsy exists. It's not so difficult to treat, but even in those treated pre-symptomatically, they have evolved an epilepsy disorder. As time goes on, it is clear that their vision is impacted. They develop a visual impairment progressing to complete visual loss or just light dark awareness. And so the CNS delivery of this enzyme replacement therapy is not enough. Of course, what are the goals of care? You know, this is a completely different phenotype now. It's a different illness. So trying to manage seizures, before I would have been managing seizures, trying to, you know, get the balance right between drug side effects and polytherapy. And now I'm thinking, no, in these treated children, we need to be aiming for complete seizure freedom. You know, we need to be treating their seizures quite aggressively because they're not in wheelchairs, they're walking around in mainstream school. In the UK, the Brineura programme is delivered, funded by NHS England, but on a managed access programme. And what that means is that the funding will be reviewed in 5 years' time, and all of the children on the programme have to go through a process of consent and have to be monitored very carefully so that we are accumulating more long-term data. And then it will be reviewed and the NHS will make a decision about whether funding will carry on. We don't know the long-term consequences. We know that abnormal storage material accumulates in all other organ systems, gut, cardiac. We're treating the brain. What is going to happen to the cardiac status of those children? What is going to happen when they're in their 20s, in their 30s? They wouldn't have survived that long without treatment. So there are many, many unknowns. Okay, I'm going to switch tack. CLN3 disease is juvenile onset Batten's. This is, in my eyes, quite a different disorder. This is a membrane protein rather than a lysosomal enzyme disorder. The protein is probably involved in intracellular trafficking. These young people develop a rapid visual loss, usually around the age of 5 to 7, around the start of school. They are otherwise healthy until the onset of seizures. The average onset of seizures is age 10. Often there are some emerging learning difficulties before the onset of seizures. And in the days when these children would have been in residential VI schools, the teachers were very good at picking out those, because the style of learning is different before the onset of seizures. During teenage years, the children, young people, develop motor difficulties, anxiety, and a very characteristic stuttering, disfluent speech pattern. And death occurs sometimes in teenage, sometimes not until the 30s or 40s. So it's a long, progressive disease. In the 1990s, studies in the lab showed an abnormal inflammatory response in this disorder. Chicken or egg? Is the inflammatory an end-stage reaction to a disease process, or is it in some way driving the disease process? That's the big question. There were a couple of short-term studies of oral steroids and also of mycophenolate. Children, young people studied over a period of a couple of years, but the results haven't shown clearly that there is an alteration or a disease modification. But that allowed investigators to think again, and I think particularly of my colleagues in the US, where to really think through, how do we do clinical trials in a very rare disorder which has such a long disease course? And although the vision deteriorates very quickly, that's when the diagnosis is made. So by the time the diagnosis is made, that first initial symptom has been catastrophic. But is there any way to prevent the seizures or the motor disorder? But then you have to study children over many, many years. So some of those outcome measures and trial design in rare disorders have been thought about. A number of pharma companies are interested. Thinking again about gene therapy, obviously stem cell therapy, enzyme replacement therapy is not an option in this group, and there's emerging, ASO kind of work ongoing, but nothing in clinical trials just yet. The small pharma companies are getting interested in these kind of rare diseases because if they can get orphan drug status, then that allows them a fast track to market. So where are we now? There's ongoing natural history studies sponsored by academics, but also commercial sponsors, and also family associations now wanting to produce registries to collect their own information. And natural history studies have to be multinational because of the rare nature of the disorder, and they have to cover all types of NCL. Enzyme replacement therapy studies are ongoing. BioMarin, who make cerulipinase alpha, Brineura, is looking at, has more kind of long-term efficacy studies in progress and are considering delivering Brineura to the retina as well as via the CNS. And then there are a number of small pharmaceutical companies who have drugs in the pipeline. So it's all very exciting. It's not fast enough. I go to conferences with the families and I say it's so much more exciting than it was 10 years ago. There's such a lot out there and people are, asking for information all the time, but it's still not fast enough. Who are the key players? Clearly the pharmaceutical industry. BioMarin, when they started the clinical trial in the UK in Hamburg for Brineura, they flew a massive team into the UK to go to the MHRA, which is our kind of drugs regulatory body. There was no way that individual clinician scientists or academics could fund that kind of team to develop these new therapies. The pharmaceutical industry is absolutely key. But so are these centres of expertise. I've mentioned Hamburg, Rochester, Nationwide Children's has a big gene therapy program in Columbus, and the family organisations are absolutely crucial. Lobbying for funding, fundraising, and now shaping research protocols and defining those outcome measures. What is really important? recruiting for studies and supporting studies. The Batten Disease Support and Research Association at the top of the slide here is the American group with chapters in many countries, very influential. The BDFA on the top right is the British equivalent, again, many groups in different countries, big membership, very active. And then there are individual family groups, associations. Taylor's Tale is a small charity based in the US, supporting other families affected by CLN1 disease infantile. But again, lobbying, fundraising, bringing clinician scientists together to get better care for children. And the Gray Foundation had funded research into CLN6 disease, and there is a gene therapy trial in progress at Nationwide. So what do we need? We need early diagnosis. We need to get these children onto disease-modifying treatment before they start to lose skills, when their brain imaging is relatively normal. We need natural history data. We need good clinicians who have experience of this disorder. We need engagement with scientists, with pharmaceutical companies. Particularly, we need a way of delivering whatever therapy into the CNS, and that's a problem. We also need to deliver therapy systemically, potentially. We need to consider the balance, the burden of treatment versus the burden of symptoms. I'm going to end there. I'll be very happy to take questions later. I want to just draw your attention to the 17th International Congress on the NCLs, which, as you see there, is going to be face-to-face or via Zoom, so anybody can attend. And I hope that I've covered some of the things that I meant to cover, and I'll just like to say thank you to all the families and children that have taught me so much over the years, the family support groups, my team at the Evelina, and all of the other groups. And this picture was drawn by a young lad with CLN2 disease many years ago now, as he was losing his sight. Clearly supported drawing, but a favourite family scene. Thank you very much for listening.
Thank you, Dr. Ruth, for such an excellent talk. It was a comprehensive overview of a very difficult disease and very empathetically spoken. We really enjoyed listening to you. We will be taking the questions in the end so that all the speakers get enough time. So I request all the audience to type in their questions into the chat box. Our next speaker is Dr. Naveen Sankhyan. He is additional professor of pediatric neurology and chief of the pediatric neurology unit in PGI Chandigarh. All of us know him very well. He has this great quality of extreme peace always all around him. And he's also a great yachtsman. So I invite Dr. Naveen to speak about the approach to chronic ataxia in children. Naveen.
Thank you. Thank you for this opportunity. I'll share my screen.
Naveen, you're muted, I think. Naveen, you're muted.
Are you able to hear me?
Yes, yes, we can hear you.
Yes. So I'll be talking of chronic ataxia in children, and this will be more like a pragmatic approach to chronic ataxia. So chronic ataxia is kind of synonymous with genetic ataxia.
Your
And
screen is not shown. Sorry to interrupt you, but you're not Your
The
presentation is not shared on the screen.
Just a minute.
screen दिख रहा है, but it is only Naveen that list of your contents. Webinars 2020, 2021, ORDI Ataxia, but it's not showing.
Is it visible now?
No, not yet. Your PPT is not open.
Okay.
You open and then share. Meanwhile, I'll just add that he's our alumnus, so it gives a lot of pleasure to be chairing a session of your own alumni.
Is it visible now?
No, not yet.
Naveen, if any issues are there, you can share your presentation with anybody and that person can share as somebody just put in the chat that you have probably traveling. So there's internet issue, but they should not be. Can you just do not stop sharing, open the slide and then share that particular frame. Don't share the entire screen.
Sir, unshare the existing screen, open the presentation and then go to share and select the presentation.
Yeah, select the part with not the whole screen, but the part of the presentation, right? Right, Mr. Prasanna?
Yeah, that's right. When you click on share, you will see the presentation.
Yeah, that's what I'm doing, but somehow it's visible on my screen.
Yes, it is right. Now you have to just expand it. Yeah.
It's there.
Yeah.
Full screen karo. Second slide dikh raha hai.
Is it visible?
Yeah.
Shall I continue then?
Yes.
This is the first slide is visible?
Yeah.
Yes.
Perfect.
Okay.
All the best.
Okay. So, as I was saying, that chronic ataxia is more or less synonymous with genetic ataxia, except for a few exceptions, which we'll discuss. So I just checked up on OMIM, and there were 1,500 responses for ataxia. This included chronic ataxia and episodic ataxia and various genetic ataxias. So this is a large group of disorders, and the outline of my presentation would be not to cover each and every cause of ataxia in childhood, and also not to discuss the genetic diagnosis and its nuances in childhood ataxia, but primarily focus on a simplified, pragmatic approach to evaluating a child with ataxia, giving few examples of classic phenotypes. And I would request that at least the pictures of the patients or videos of patients be not saved in respect of their privacy. So what is ataxia? Ataxia literally means lack of order, and we are all familiar with seeing children with ataxia. They have difficulty walking, balancing, speaking, swallowing, and particularly it is evident in tasks which require high degree of control, particularly writing and eating. So broadly, ataxia we discuss is generally cerebellar, but we also get patients with sensory ataxia, sometimes ataxia due to vestibular dysfunction, very rarely due to optic dysfunction, that is primarily in adults, parietal lobe dysfunction. Occasionally, we get epileptic pseudoataxia and psychogenic ataxias. So basically, ataxia is a common reflection of various structural injuries to the brain. It can be a genetic or metabolic cause, or it could be a degenerative condition. We had the talk on NCL, and NCL is also a cause of degenerative ataxia. When one looks from a clinical perspective, from the perspective of onset, it can be either acute, intermittent, and chronic. Most of the discussion today will be on the chronic ataxia. It could also be progressive and non-progressive based on how we follow these patients and what happens to their ataxia with time. So there are some things which are peculiar and which are related to how embryologically cerebellum develops. So peculiar to cerebellum is that it has a very protracted developmental timeline, and the development of cerebellum from in utero continues for several years after birth, and that is why there is a long period of vulnerability for this part of the brain. And the second thing which is important to remember is that cerebellum and brainstem are closely linked functionally as well as from an embryological perspective. And we'll see why this is important in few examples. Also, the thing to remember is that there are several genes which are involved in not only the development of cerebellum, but also in its function. And that is why you have a wide array of dysfunction and a lot of disorders which affect the cerebellum directly or indirectly. And one example I would give is in prenatal cerebellar disruptions. And you can see this table given by these authors, which shows that while cerebellum is not so affected by hypoxic ischemic insult or postnatal infections or prematurity related brain injury, but there is a particular predisposition for having cerebellar dysfunction and metabolic disorders due to toxicity of certain drugs and also due to prenatal hemorrhages. So how do we evaluate a child with ataxia? The usual problem is that in a busy OPD, what happens is you subject the patient to an imaging, and the problem is that you don't get a diagnosis after imaging. But the newer problem that we are facing now is that you end up doing the genetic test first. And once the genetic test is negative, you start wondering, oh, I should have taken a detailed history and examined this patient. Why has the NGS report come negative? And chronic ataxia is one situation where the next generation sequencing is not going to give you the answer every time. So what I suggest is a more pragmatic approach and based on the good old method of good history taking and good clinical examination, and then evaluating the investigations in light of what the clinical evaluation suggests. So beginning with the onset and course, if it is abrupt onset, generally it is due to toxic or demyelination or other acute insults, but there are exceptions. You can have metabolic ataxias or genetic episodic ataxias which can have abrupt onset. The more insidious onset, gradually progressive ataxias occur in degenerative conditions, with exceptions being tumors of the brain. The early onset static ataxias generally indicate that there are structural abnormalities in the hindbrain, particularly the cerebellum, and they could be genetic, but one has to also remember that abnormalities in myelination also lead to early onset static ataxia. From a clinical perspective, it is important to remember that very slowly progressive ataxias may mimic static ataxias if you don't observe the child for long, plus the developmental gain of cerebellar functions may outpace the degeneration. So this is seen in CoQ deficiency or congenital disorders of glycosylation, certain variants. So next comes the age of onset, and it is important to differentiate in the ataxias based on age of onset. So the infantile onset ataxia is generally due to structural causes or due to a congenital deficiency in myelin development. The early onset ataxias, the classical phenotype is the ataxia telangiectasia, but you could also get early onset mitochondrial diseases as well as some syndromic ataxias. We'll see a few examples of these disorders. In the older children, the classic phenotype to remember is the Friedreich's ataxia and its differentials. And rarely in children, you would get a spinocerebellar ataxia. Coming to a case scenario, now we evaluated these two children who were born to non-consanguineous parents, a 4-year-old girl with microcephaly, spasticity, ataxia, and global developmental delay, and her younger sibling, who was 1-year-old, had global developmental delay, spastic, and also had a static course. And the imaging was fairly characteristic. You can see this flat belly of the pons and the atrophy, rather the hypoplasia of the cerebellum. And the diagnosis was pontocerebellar hypoplasia. But our job does not stop here. You know that pontocerebellar hypoplasia is a group of conditions with distinct genetic causes. And to add to this complexity is that there are several disorders, both genetic and non-genetic, which can cause pontocerebellar hypoplasia, like different mitochondrial disorders, or you have congenital disorders of glycosylation, and even congenital CMV, which can lead to pontocerebellar hypoplasia. So once you have this phenotype, you have to evaluate these patients further to know that what is the actual cause of pontocerebellar hypoplasia. Let's see another case scenario. This 4-year-old boy Parents were consanguineous. He had motor predominant developmental delays noted since early infancy. He had hypotonia, and his ataxia was static. Let's see one of the clinical signs that was evident in this patient. So one can see that this child has difficulty changing gaze from one direction to another direction without moving the head. So this is the oculomotor apraxia. So summarizing, this child had a static ataxia, onset less than 2 years. There was no family history, but had oculomotor apraxia and nystagmus. His brain imaging was characteristic. It showed the molar tooth sign. And one other abnormality that is seen in this condition is the horizontally placed superior cerebellar peduncle. You can appreciate this and compare it with what a normal superior cerebellar peduncle looks like. So this was Joubert syndrome. And again, this is not a single condition. It's a clinically and genetically heterogeneous condition. And as of today, 37 subtypes are known. Various genes are described, and they have various other associations, except for the common ones being developmental delay, some abnormality in breathing. You have variable involvement of retina, renal diseases, other ocular involvement, abnormalities, hepatic fibrosis, polydactyly, and other abnormalities. So again, this is a group of conditions. And once you have the imaging phenotype, you can go ahead and work them up for the different causes. This was an interesting paper on diffusion tensor imaging in patients with Joubert syndrome. And on the right, you see the normal DTI. These are the tracts which are shown in the brainstem, and these red dots, red lines rather, which are marked by these white arrows and arrowheads. These shows decusating fibers, and you can see that on the left-hand side, this is a patient with Joubert syndrome who has no decusation at the superior cerebellar peduncle or of the pyramidal tracts. Here is another child, and you can see the clinical findings shown in this video. Again, you can see that the eyes don't follow the head, and rather the head has to be moved to change the gaze from one direction to another. So this was a child who was intellectually spared, had very minimal signs in terms of imaging signs, but she again had Joubert syndrome of a mild variety. So coming to the next point in clinical evaluation, it would be the family history. So a detailed family history, a 3-generation family history is very important in evaluating any genetic disorder, and cerebellar diseases are no exception. If you don't get a family history, and particularly in young children, suspect autosomal recessive cause. If it is positive, then you need to see the pedigree and decide whether it is a dominant recessive or other mode of inheritance. Plus, you have to also remember that certain disorders are peculiar to certain ethnic groups, and so family history becomes important in that sense as well. So I'll just share another case scenario. So this was an 8-year-old girl that we saw, and she had ataxia beginning at 2 years of age. So when we evaluated her at 8 years, she had this difficulty in tandem gait. She had other signs of cerebellar involvement like pass pointing, dysmetria, intentional tremor. And these are important bedside tools. So she was asked to make a Archimedes spiral, and you can see how she performed. She could not draw a ladder, and this all indicated that she had cerebellar dysfunction. So when we examined, she also had oculomotor apraxia. Her imaging showed very mild cerebellar atrophy, predominantly of the vermis. So when we took the family history, she had on the paternal side a very strong family history which affected 3 generations, and in each generation the person getting affected was at a younger age. So it all indicated an autosomal dominant inheritance related to triple repeats. So just summarizing, onset 2 years, autosomal dominant possible with anticipation, had ataxia with oculomotor apraxia and mild cerebellar atrophy. So we thought of a dominantly inherited early onset ataxia, though this is uncommon, but this is what this patient had. So her profile for ataxia telangiectasia was negative, and genetic testing confirmed the presence of SCA2 in this child. A little more on the family history because it's so important in evaluating these patients. This was a 6-year-old girl who had been brought with clumsiness, and she had rapidly progressive ataxia with cognitive regression for the past 2 years. She also had few seizures, and a very strong family history. So this was the index child, the proband. So father was affected, uncle was affected, and so was the aunt, and grandparents and great-grandparents were also affected. And again, in each generation, the age of onset was declining. So this particular individual here had an onset at 40 years of age, and whereas the father had onset at 20 years, and this child had onset well before 10 years of age. So the video of the patient suggested that she had less of ataxia and more of posturing. And while the aunt who had brought the child for clinical evaluation, she said that the father has definite instability in walking. We wondered, what is this, a complex phenotype, and why there is a difference in phenotype. So we asked, because the parents could not travel, so we asked for home videos, and the home videos, if you see, clearly suggest that the father does not have ataxia, but he rather has a movement disorder. And the imaging showed the characteristic atrophy of the caudate and the putamen, and thus establishing the diagnosis of Huntington's chorea, which we established after genetic testing. So the important clinical point is that we need to recognize the family phenotype, get all possible information about the patient, review home videos, and these home videos are very valuable for individuals who cannot be examined. And so unless you have the full information, the clinical information, it is difficult to pinpoint the genetic cause. So this again is a disorder which was difficult to diagnose just based on genetic testing. Unless you have a clinical phenotyping accurately, you cannot diagnose these patients. Now coming to additional medical and neurological and somatic features. So it would be important to do a good general physical examination and a neurological examination in these patients. So some of the points which are important in the general examination would be whether there is presence of short stature, abnormal skin or aged appearance, telangiectasias, xanthomas or lipomas. So here is an example of a child, and look at the facial appearance where there is, photosensitive rash, a little old looking appearance, failure to thrive. The patient had basal ganglia calcifications and had myelin abnormality and thinning of the cerebellum as well as thinning of the corpus callosum. So this was Cockayne syndrome. The other points in general physical examination would be the head size and ocular abnormalities, because these are common in many chronic cerebellar syndromes. So a large head with this kind of MRI is diagnostic of megalencephalic leukoencephalopathy with subcortical cysts. You can appreciate the diffuse white matter changes as well as the anterior temporal cysts. Now, one needs to differentiate basically patients who have pure ataxia versus those who have ataxia plus syndromes. So if you have ataxia plus myopathy, consider mitochondrial disorders. If you have ataxia with neuropathy, then you consider Friedreich's ataxia, other inherited neuropathies which can present with sensory ataxia, or mitochondrial disorders which can have ataxia as well as peripheral neuropathy. The other important neurological abnormalities include cognitive dysfunction, which would indicate a late onset storage phenotype, or a leukoencephalopathy or DRPLA. If there is presence of spasticity, consider post-progressive spastic paraparesis and other autosomal recessive SCAs SCA3 particularly can have both spasticity and Parkinsonism. So one cannot remember all these details. You need to open up your books, first identify the clinical sign, and just match phenotypically what is happening to that particular child. And to add to the features, over the last 2 decades, we know the now well-established entity of cerebellar cognitive affective syndrome. Initially, cerebellum was thought just to mediate the motor manifestations and cause dysmetria, but now we know that it clearly, both acute cerebellar disorders as well as chronic cerebellar disorders can have mood changes, behavioral abnormalities in language, both expressive as well as in understanding, as well as impaired executive function. So after a good clinical phenotyping, one can really look at the imaging. Sometimes the imaging may be diagnostic in isolation, but more often, if it is combined with a good clinical phenotyping, your task becomes simpler. So what you can rule out with imaging is clearly other causes like tumors, infarcts, infections, and demyelination. Imaging would be very valuable in disorders of myelin, and you can see the patterns of myelin abnormality and decide on which disorder you're dealing with. Again, it will be diagnostic for cerebellar malformations, and you can also check for other areas of involvement in the neuroimaging, which will give you additional clues. So MRI, basically, if it is normal or non-specific, and you have a chronic ataxia, particularly in an older child, consider Friedreich's ataxia or one of its differentials. If you have cerebellar atrophy, then you consider the ataxia telangiectasia phenotype, SCAs, storage disorders, and mitochondrial diseases. If there are white matter changes, then you think of disorders of myelin. If you have a structural anomaly, then you think of syndromes of cerebellar development. And if you get any other lesions which are clearly diagnostic of something else, then you don't think of genetic ataxias. So here is an example of a 3-year-old with static ataxia of infantile onset, and he's cognitively relatively preserved. You can see on right-hand side the abnormal myelin in the T2 weighted image in a 3-year-old child. And on the left-hand side, the myelination looks rather normal in a T1 weighted image. So this is the pattern of hypomyelination. Here you see a 3-year-old boy with progressive ataxia, which worsens when he has fever, and he has normal head size. His ataxia is very, very slowly progressive. He has some cognitive issues and mild spasticity, and this is the vanishing white matter disease. So one more point regarding this disease is that while affected individuals have chronic ataxia, it is the mutation carriers, the heterozygotes, particularly females, they may develop premature ovarian failure. Here is another ataxia which has a signature imaging finding, and this is the autosomal recessive spastic ataxia of Charlevoix and Sanguinet. And you see these, they have the characteristic superior vermis atrophy combined with these linear flare suppressing lesions in the pons. So once you have some kind of phenotyping, I think what you need to do is further directed genetic testing. And what you get is not always through NGS, because you need to do certain panels, and nucleotide repeats are something which need to be seen in these patients. So just I would describe the 2 classical phenotypes in ataxia: the cerebellar, the early onset progressive cerebellar syndrome. So this is the phenotype which is important to remember. A 7-year-old girl presents with slowly progressive unsteadiness onset at 2 to 3 years of age, no other contributory history. And she not only has ataxia, but she has these telangiectasias over the conjunctiva. And apart from this, she has impaired finger taps. She has impaired foot taps. And she has spontaneous dystonia of the lower limb. And she has oculomotor apraxia with very fiery red eyes. So this is ataxia telangiectasia. And from a clinical standpoint, you need to remember that they initially present with ataxia and extrapyramidal features. And at that time, they may not have telangiectasias. The oculomotor abnormalities, particularly the apraxia, this appears later on. Telangiectasias may be delayed in appearance as late as 4 to 6 years. And finally, in late childhood or early adolescence, they develop predisposition to neoplasias and recurrent sinopulmonary infections. So it is the phenotype which needs to be remembered, and the differentials also need to be remembered. So once you have a child with early onset ataxia and abnormal eye movements, apart from particularly in those without the ocular findings, you would think of juvenile Niemann-Pick disease, Gaucher's disease, syndrome of ataxia oculomotor apraxia, and autosomal recessive spinocerebellar ataxia. If you have the ataxia with immune deficiency phenotype, you think of the very rare purine nucleoside phosphorylase deficiency. If you have ataxia with predisposition to cancer, then the Nijmegen-Breakage syndrome should be one of your differentials. Here again, one practice point is that those who are carriers of the heterozygous carriers of the ATM gene, or they carry a mutation in the ATM gene, they are at risk for developing ischemic heart disease, developing cancer, including breast cancer. And in these patients, a more intensified surveillance program is indicated, particularly for women who are predisposed to breast cancer. So this can happen in carriers, and so we have to just not take care of the child, but also keep track of the parents. They are also predisposed to develop cancers. The second phenotype that you need to remember in childhood is the Friedreich's phenotype. So this is again a little later onset, generally early adolescence is when they present. They have ataxia and they have polyneuropathy. They frequently have musculoskeletal complications like pes cavus and scoliosis. A proportion of them will have diabetes, cardiomyopathy, but they have no cerebellar atrophy, and this is the spinal component, spinocerebellar ataxia. So they have sensory as well as cerebellar ataxia. So the important to remember in this phenotype is that you have a similar phenotype in other autosomal recessive conditions like the ataxia with vitamin E deficiency, A-beta lipoproteinemia, and hypo-beta lipoproteinemia. These are treatable disorders and important to remember as differentials of the Friedreich's ataxia phenotype. And adding to that, there would be other disorders which can present in later childhood like late onset Niemann-Pick, CDG, Lake syndrome, MRF, and late onset SCAs, which would form differentials of these patients. So one should never forget the treatable causes. And while this slide shows the various treatable causes of ataxia, among the chronic disorders, you can remember that ataxia with vitamin E deficiency, A-beta lipoproteinemia, cerebral tendinoxanthomatosis, Niemann-Pick, Friedreich's, Refsum's, CoQ deficiency, and some of the immune-mediated ataxias can all present with progressive ataxia, and they are potentially treatable. So these are the causes one should never forget, and in all patients, you should check the list and exclude each of them systematically. So a quick recap on what we have discussed already. So chronic ataxia in children is a long list of conditions. They are individually rare and they are heterogeneous, both clinically and from a genetic perspective. 40 to 50% of these children remain undiagnosed despite the best of workup, as distinct from adults where they get generally autosomal dominant spinocerebellar ataxias. The recessive forms are seemingly more common in children. And we should never forget the few treatable causes. One has to really rely on traditional history taking and examination to diagnose these patients accurately. And with the advances in genetics and the number of conditions being described with ataxia, it's a good idea to first phenotype the patient clinically and then look up the literature for the causes. So I thank you for your patient listening, and I'll be open for happy to answer any questions. Thank you.
Thank you, Naveen, for a very excellent approach and overview. Now, I think we will request all three speakers who had excellent talks for the replying to the queries. So, first question is role of whole exome sequencing in diagnosis of gray matter disorders. Who would like to take this question? Yeah, please go ahead.
Yes, so
yeah.
See, when we say gray matter disorder, it's a huge list of disorders. So, you will have patients who have primary cortical degeneration to begin with, then you'll have patients who have basal ganglia degeneration, also will be classified as gray matter DBD. So, as I said in my talk also, the first thing is to have a very good clinical phenotyping, because exome sequencing should come after your clinical phenotyping. Frequently, what you will get is non-specific VUS or variants of uncertain significance. And sometimes you'll pick up just one variant, whereas the disease, what you're suspecting, is autosomal recessive. So you have to be reasonably certain of your clinical phenotype before you embark upon clinical exome. And one should never forget that any disorder which has a biochemical signature, please first get the biochemical signature before you do the exome sequencing. So I'll give you a few examples. So like in ataxia telangiectasia, you will have the raised alpha fetoproteins. So do that before you go for exome. In NCL, if you are suspecting the early onset forms, do the enzyme assays and be sure that you have a clinical and biochemical phenotype before you really go on to clinical exome. So don't go for clinical exome first and then try to phenotype it. Phenotype first and then evaluate the clinical exome.
Actually, it's important, and otherwise we have to also remember that sometimes radiology also helps us. So as very rightly Dr. Karuna has shown, and we have to think radiogenomics started off with basically oncology. It started off with neuro-oncology actually, but now it is just giving, like, for us it's we have to strategize what we are going to advise. So I think it is very important for us to take aid from neuroradiology. Dr. Karuna, would you like to add something onto that before Dr.
Yeah, definitely. And I think the more that we have started recognizing all these genes, and their imaging signature, we kind of have started even, in the reports suggesting to please test for the specific gene if we have specific imaging patterns, particularly like the biotin thymine, which is treatable and, has pretty, classic imaging phenotype, so those are some things like we have actually incorporated, putting that in our reports to suggest which genetic testing, specific gene to be tested. I think this is just going to go on increasing more and more as we learn more about these specific mutations. It'll be just difficult to keep up, it'll be quite a few of these being recognized.
Dr. Gauri, you ask the next question. Yeah.
The next question is from Dr. Vinay Kumar, and his question is, what are the ataxias with cognitive impairment in children? That's a good clinical handle to start with. So I suppose the question goes to Dr. Naveen.
Okay, so some degree of cognitive impairment is seen with most cerebellar disorders, but if you have regression, then you would think of storage disorders presenting as chronic ataxia. So if you remember all your progressive myoclonic epilepsy phenotypes, all the differentials which come in PME will form differentials for chronic ataxia with cognitive impairment, number one. Number two, you have the mitochondrial disorders. Number three, you have the congenital disorders of glycosylation. And number four, the peroxisomal disorders. So these are broadly the disorders which have cognitive impairment along with ataxia. Plus, some of the SCAs also have cognitive impairment, but they are uncommon, particularly in young children.
Yeah, thank you.
Use of riluzole, experience with riluzole has been asked. Experience with use of riluzole in chronic ataxia. Mahesh has asked this.
So I have no personal experience with using riluzole.
Okay.
Mahesh,
if you would like to share your experience.
There is one question from Dr. Naresh, which Dr. Naveen will be happy to answer. Do you think vitamin B12 can be a close differential diagnosis of chronic ataxia, which is easily treatable?
I don't remember seeing any patient with chronic B12 deficiency coming with chronic ataxia. But yes, in older children, particularly if they have secondary B12 deficiency, It can cause posterior column involvement with spasticity and sensory ataxia. So theoretically, yes, but somehow I have not encountered pure cerebellar ataxia as a manifestation of B12 deficiency.
What is your experience regarding the use of steroids for ataxia telangiectasia? Lots of question for Naveen. Huh? Maybe because the last one. That's why now they're remembering for the Q&A. Yeah.
Okay. So at the moment, I would not suggest it as one of the treatments. The only treatment that is suggested in ataxia telangiectasia is that if they have frequent sinopulmonary infections, then monthly doses of immunoglobulins can be given to for reducing the frequency of infections, because they have an inherent immune deficiency. So that can be partly corrected by monthly immunoglobulins, and that is the only definitive treatment you can give in ataxia telangiectasia. But from a practical standpoint, the other important thing to do is never do a CT scan and avoid X-rays as many as possible in patients with ataxia telangiectasia, because they have this tendency for chromosomal breaks and they can have secondary cancers. So it's important to avoid exposure to radiation.
I may like to add that Iridil is just winding up the analysis of intraerythrocyte dexamethasone. So they are doing the analysis of the primary objective. So the primary outcome, it got sort of, it got very badly affected by the COVID, because we were also a site in which you were giving every 3 weekly intraerythrocyte DEXA, So they are analyzing with whatever data could have, and we would be probably having an answer to that, but that's an intraerythrocyte dexamethasone. Dr. Gauri?
I have a question for Dr. Williams. You mentioned the use of steroids in NCL3 and MMF in NCL3 and some role of steroids. I once came across a paper describing using prednisolone eye drops for the visual aspect of NCL. Is there any role of that?
I don't think so. It's a retinal degeneration, and we think that part of the visual failure is central as well as retinal. So I can't see how topical steroids is going to change that.
Dr. Ruth, another question for you. I just want, before I ask you the question, I just want to tell everyone that guidelines you have come up with recently are absolutely wonderful and totally, I mean, it's a must read. Just take home for them is a must read in the Orphanate Disease Journal. And Dr. Pavan has asked you whether you need a OMAYA and ERT, although that's answered in that guidelines, but I would like him to hear from you. Yeah.
Yes, the children need a MAIA or a rectum reservoir inserted before they can have the enzyme replacement therapy. That's how it's delivered.
So there's a question for Dr. Karuna by Dr. Naresh. Vigabatrin is said to be very useful in TS. So how does one suspect vigabatrin toxicity, and what should be the alternative drug if vigabatrin is stopped?
I think this was something, which even we had the question, like, why use vigabatrin when we are getting these things on MRI? But I think this was in the initial phase when we were getting like more cluster of these. But now we don't see that many of them, probably because the dosage and everything is probably adequate. And then there was this study which was done, which showed that that these brain abnormalities are not always symptomatic. There are very rare, the times that they may be symptomatic are very few. And I think that one paper had said that probably it was like just the dose related part. And I think combination with certain medications. I'm actually not qualified to answer the treatment part of the question, but this was a question which even we had, like, why give vigabatrin if it is producing toxicity? But the neurologist told us that it's extremely effective in controlling infantile spasms and is the drug of choice. And it's And if it can be, given, that would be like maybe by reducing the dose or temporarily stopping it, I think they would do it. I think about the treatment, probably you guys can give a better, I think,
Yeah,
highlight
there's a lot of work by Dr. Sean Hussain from UCLA and Dr. Pearl. They've done a lot of work about vigabatrin toxicity, and generally the recommendation is to just reduce the dose first, because this is not a permanent
Yeah, they're
damage.
reversible. Yeah.
So very often reducing the dose will solve the problem, and they are usually picked up because they suddenly develop these movement disorders and dystonia. So,
Actually, we in India had been more scared. I mean, but the data now, when they say it's not that common, not that worrisome, and that's what has been put in this CDC website as well. Dr. Ruth, another question: are there any anti-seizure drugs which work better in your cohort in terms of seizure control? How does the EEG change over time despite clinical control of seizures?
So the EEG, apart from the response to photic stimulation, is very non-specific, and it just shows an epileptiform EEG. I find that because myoclonus is a big part of the late infantile onset NCLs, I avoid carbamazepine, lamotrigine, and phenytoin usually. For some children, those seem to work really well, but I have seen several children go off their legs because they've been prescribed carbamazepine or lamotrigine, and when it's been discontinued, they have regained some motor skills. But that's early on. So my preferred options are sodium valproate, clobazam, levetiracetam is quite helpful too. Ketogenic diet I've used in a number of children, and without any adverse consequences and possibly improvement in seizure control. But valproate, benzodiazepines are I think the drugs of choice.
is there any advantage of the AMPA antagonist like perampanel?
Sorry, I missed that.
Is there any advantage of the AMPA antagonist like perampanel?
I have only seen it used in 2 or 3 children, and I haven't seen significant benefit. So theoretically maybe, but I haven't seen the benefit. But I don't know what other people's experience of perampanel is generally. I'd be interested to hear.
I don't have any personal experience, but we were researching it, and there's some data that it has a slight advantage in NCL. So that's why I asked you.
Yeah, but we don't have personal experience as of now. Yeah, we also don't have. Dr. Naveen, episodic ataxia with normal imaging in children present a big challenge. Can you enlighten us on possible differential and useful empirical treatment options?
So episodic ataxia, episodic ataxia would be generally would not have clues on the imaging, particularly if it's a genetic episodic ataxia. So the only situation where you will have an imaging clue with episodic ataxia is when you have an inborn error of metabolism presenting as episodic ataxia. Like if you have MSUD presenting as ataxia, or if you have a urea cycle disorder, or a mitochondrial disorder presenting as episodic ataxia, there you will get imaging signatures. But most of the other episodic ataxias are genetic episodic ataxias with no imaging signatures. So they will be diagnosed again by clinical phenotyping. When I say clinical phenotyping, I mean, radiology is, inherent in interpretation of the clinical phenotype, and then going ahead with genetic testing. So empirically, you could use estazolamide or as one of the channel blockers to see the effect, but it will be limited to those who have frequent and disabling episodic ataxias. But it is better to have a genetic diagnosis before embarking upon empirical therapy.
So there is a question on, yeah, please go ahead, Dr. Karuna. You wanted to say something?
No. I was just looking through the question.
Dr. Gauri, Professor Kalra has raised her hand. Prasanna, can you please unmute Professor Kalra? She wants to speak something. She has raised her hand. Mr. Prasanna, is it possible? Meanwhile, one thing before he's unmuted, may I request our esteemed speakers to give us a take home, like that rapid fire, to give the take home messages. So, Dr. Karuna, just what do you want the audience to remember? 5 points you want us to take home. Yeah.
No, I think all the treatable causes and things that have characteristic imaging signatures, they should be utilized as the starting point. And there are many conditions which are overlapping. So, diseases don't read the books. So there may be many times exceptions, that not all the things may be present, not all imaging findings would be present, but it's a good starting point. I think it's the good, like the first point to initiate all the work. So at least you can sort of not go on extensive genetic testing, but you can at least kind of focus on, which group of things that you are looking at, So I think it's an essential part of the initial examination itself. And MRI is the way to go, and using, specifically if you have, clinical suspicion for mitochondrial or other things, whatever history is available to all the ordering physicians, we always encourage, like, give as much as history and examination findings that you can give, and we can actually then focus and get a better study in the children, particularly like use of specific sequences, like the susceptibility weighted imaging. We don't do it for all, but if there is a clinical suspicion for this, then we will definitely use that. So I think all clinical information and examination findings are very helpful to put all the pieces together for these challenging diagnoses.
Thank you so much, Dr. Ruth. Your messages.
Yes. I think the main message is about children presenting with CLN2 disease. Because there's a disease-modifying therapy available, it's about early diagnosis. So a child presenting with language delay and seizures, age between 2 and 4, think CLN2, do the EEG with photic stimulation, and then the enzyme test. That's my message.
Thank you. That's very clear. And Naveen?
So 2 messages. Number 1, never forget the treatable causes of chronic ataxia in children. And number 2, be in close touch with your colleagues from neuroradiology and from genetics. Everything has to go hand in hand. Neuroradiologist cannot do a good job unless you give him the good information. And the geneticist will misinterpret the variants he has detected if you have not given good clinical information on the form. So unless you do these 2 things, you would be lost in any neurodegenerative condition.
Has to be a multidisciplinary approach, absolutely multidisciplinary approach, and taking help from both the sides. Yeah, it has to be a trio there. So this is another trio. This is the clinical trio. Dr. Gauri, you can make your final comments.
wants to speak, and I think she's been unmuted.
I'm trying to ask them to unmute. They are trying. Ma'am, can you please accept the invitation to be unmuted? You have been trying. They're trying to unmute you.
My
yes,
suggestion is that taurine has been used on a long-term basis to prevent toxicity from Vigabactrin. And I think that's something we should see and follow when we use Vigabactrin on a long-term basis. That relates, and I don't know whether it relates to the radiological features that was pointed out in the talk.
Yes, I have also used it in some children. It seemed to be helpful, but it's like very small number of cases.
Thank you, ma'am. Thank you, and sorry it took long to unmute you. Yeah, thank you.
No, I didn't know how to do it. I didn't
No,
know
ma'am.
I didn't know how to type it and send.
No, that's fine. That's fine, ma'am. Dr. Gauri, can you just put the concluding remarks before you hand over to Anne?
Yes, there's one clinical question which Dr. Anne wanted me to ask, and that is there any significance of ataxia with limited upward gaze? So,
Because we have
मेरे को तो नहीं होती, मेरे को तो बस इतनी चाहिए. So eat,
So,
something. मुझे तो नहीं होती.
if you have gaze abnormalities with ataxia, there are certain clues. So if you have a up-gaze palsy, it indicates Niemann-Pick type C. If you have a horizontal gaze palsy, it will indicate Gaucher's disease. If you have ophthalmoplegia, particularly with ptosis, think of a mitochondrial disease. So if you, and of course, I showed you various examples of oculomotor apraxia, hypometric saccades, and a range of abnormalities which can be seen in other cerebellar disorders. So eye abnormalities are very important, and gaze palsies are very important in differentials of chronic ataxia.
Thank you all for an amazing session. Thank Anne for opportunity. Thank you, Gauri. Thank you so much, Dr.
Thank
Gauri.
you. Thank you.
Thank you, Dr. Williams and Dr. Karuna and Dr. Naveen for taking time out, especially during this time difference and everything. And thank you to our moderators and Mr. Prasanna. Thanks to everybody. So that's the invitation for our next talk, which is a bit more an area where most of us neurologists feel a bit uncomfortable with, more neurodisability type, but very important nevertheless, very important part of our MDT. As Dr.
And we are very comfortable with it. It's something close to my heart. You don't say that you are uncomfortable.
I mean, some of us more than others.
And that's all right.
Yes.
Yeah, it's something very nice and very important.
So it would be nice if many students and many of us partake of it. So enjoy the rest of your weekend. Thank you, everybody.
Thank you.
Thank you.
Bye.
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 everyone.
Bye.
Thank you.
One last thing.